All right. Yes, thanks again, Dr. Whitman, for joining us. This is the next in our Western New England Lunch and Learn series for our preceptors, both near and far. So, Dr. Arin Whitman is a clinical associate professor of pharmacy practice here at Western New England University College of Pharmacy and Health Sciences. She practices at UMass Ambulatory Care Center in the Hematology Oncology Clinic. She is always a favorite preceptor for our students, a very sought-after rotation. And today she's sharing with us a lunch and learn on diversity, equity, and inclusion in pharmacy practice to enhance patient care. So, Dr. Whitman, take it away.
Well, thank you for the lovely introduction. And the purpose of today's topic is, at times I've gotten questions from students in relation to what is our role as pharmacists, right? And the DEI sector, there's lots of topics at the hospital in relation to how physicians and nurses work with different types of patients, but often it's not really geared towards pharmacists and what is our role and what is the importance of understanding some of these principles and what we do. And so we're going to talk about, key principles that actually affect our role in patient care. And I'll give some real world case examples of when it's actually been important to think about these things as a pharmacist. And so first we want to define, right, what is DEI? Because a lot of people feel differently, focus a lot on social issues in relation to DEI, but really the important thing when thinking about what does it mean in healthcare is understanding differences among individuals, because the care that I provide for my patients might be different based on certain beliefs that patients have, individual religions, or potentially abilities, and what we might do. For example, I heard an example about, well, if I have a patient who's in a wheelchair who develops diabetes, and I'm probably not going to go in and talk to them about the same exercise habits that I would talk to another patient about, right? And it's something that's so subtle, but something that sometimes we don't think about in advance that, there are ways for people to exercise and get exercise in a wheelchair. And what are those? And am I prepared to talk about those if I have a patient who needs that? In terms of equity, this is about providing fair treatment, access, opportunity, and advancement. And where I see this is, we do a lot of work in the AM Care Center here to make sure that patients can afford the treatments that are best for them. It's one of the biggest issues in oncology with our oral agents. Copays can be extensively high. And so we have specialized technicians who do a lot of work to make sure that if it's possible for us to get them free or reduced drug, we do. And we do the work to help them to get it, so that they can receive what the physician thinks is the best treatment for their cancer and not necessarily what's the cheapest. And then in terms of inclusion, this is just the extent to which individuals feel welcomed, respected, and supported. And this is important, because when you think about going to the pharmacy or even to the hospital, I always have to remind students that we live here, we're here all the time, but patients aren't always in these spaces and they're nervous. They may have not been in the hospital since they were born. And so, kind of coming in and feeling like, oh, I'm nervous, I'm not sure. And being able to feel like, oh, the pharmacist actually listened to my questions and they answered my questions. And, I thought they were dumb questions, but they made me feel comfortable asking. And that helps to build a relationship, right? Where when a patient has an issue, or I have patients with adherence issues, where I feel comfortable and they feel comfortable talking about it and being honest. So thinking about these things in terms of healthcare, right? One of the things that we focused on is personalized medicine. That's the future in healthcare, right? Especially when I think about oncology, we do so much targeted therapy, use of pharmacogenomics, but there's also patient-centered care that aligns with different cultures and social needs that patients have. Even since the student I have now has been here, we have patients who might have religious beliefs that affect what treatments we can offer and provide for them. But that doesn't mean that we don't want to treat them at all. we might have to come up with an alternative. And so, one example we were just talking about that we had was a patient who was a Jehovah's Witness and did not want blood transfusions, right? There are a lot of things that we've done off label to help support blood counts, like making sure iron is supported, doing things like using erythropoietin stimulating agents off label, right? We do have a conversation with the patient that this isn't what we would typically do, but if patients have these strongly held beliefs, we're not just going to not treat them. I'm going to try and to find a way around that and still offer them the same level of care. And so I think trying to, as pharmacists, to proactively at least be aware of these things can help us so that when we get these questions from providers or from nurses, we're kind of ready with, okay, here's some things that maybe I need to think about. The other thing is thinking about the social determinants of health, because we know that this is something that affects outcomes for patients, and it does affect people's ability to stay compliant with medications. When I think about things such as there's been a lot of pharmacies that are closing, and what areas are they closing? If I have a patient who needs a methadone clinic, but it takes them 2 hours to get to the closest methadone clinic every day, we're writing in the note inpatient that they're not compliant, but how could they be compliant when they're spending 4 hours to get this one drug every single day, right? Or being able to connect patients to financial assistance programs for affordability. A lot of times we have these copay cards sitting at the counter, but does the patient actually even know what that is? Did they know that they could use it? Are we actually taking the time to spend with them to say, hey, here's this resource. I maybe don't have an hour to walk you through it, but check out this app. Check out this, coupon code that's there that might help them to be able to afford medication or get around transportation issues. I know some pharmacies offer delivery now, even for older patients during the winter time. That can be something that's really helpful for them to be able to stay on top of their medications. In terms of equity, this is the focus on meeting individual needs, not providing identical solutions for everyone, but what does one person really need in order to have equitable access to things? And so, again, for us, that means focusing on things like costs, access, awareness of resources that can be barriers to patients being compliant or adherent to medications. So to not just always think about it as, oh, well, this is a bad patient or a patient who doesn't want to get better, but okay, what are the barriers and what can I do to help this patient to get around those barriers? And things for me, really, I always keep at the top of my list in oncology is cost. That's always one that, I make clear with patients in the beginning that we're going to see when we do the PA, the copay might be $17,000. Don't get alarmed yet. We're going to do some more work, right? Because, some patients might walk away when they see that, but okay, we're going to help you. We're going to work with you. And I've, seen our technicians take a $17,000 copay to a $50 copay. And that makes a huge difference, right? In whether or not a patient can actually adhere to treatment. So when thinking about considerations for pharmacists that are important for us is I always remind students, right? I don't have to agree with everything the patient wants to do, but I do have to try to work with them to make sure that in the end, am I getting them the best treatment that I can? And so that might mean that the patient does something that I'm like, I wouldn't do that. That's not the best care. But at least, okay, what can we do to try to make sure that we're at least improving your condition, improving your life more than what we have here? Some of that might come down to also health literacy is sometimes we sort of forget as pharmacists that we know a lot of things and we think that it's obvious, right? It's like, why wouldn't you get a flu vaccine? But there are a lot of people who don't understand, right, the roles of vaccines. And with technology, they're hearing a lot more from people on social media who are not pharmacists than they are from us about these things. And so just being aware of the misinformation that's out there ourselves and being prepared to kind of speak to it is really important. And so, I always tell students, I watch the news not because I believe or care in everything that's on the news, because I want to hear what the patients are hearing. So then when they come to me with, well, I heard this, I'm ready to speak to it. Well, I actually looked at that trial, and this is, why that's not accurate, because that can help. The other thing to think about is representation in materials. And I mentioned the example of, a patient in a wheelchair earlier, because it's one thing that I had not thought about myself until recently when I've worked with someone, how we often talk about different ethnicities and genders and ages, but we don't often have representation in materials about people with differing levels of abilities. And there are a lot of non-farm education things that sometimes we educate our students on that we don't realize, are not universally applicable to all patients. So, not every patient can walk or swim for exercise. So, what are other things that are in my wheelhouse that I'm aware of, right? That I'm prepared to talk to a patient about so that they don't feel like, oh, you know, they're not even thinking about people who are like me who have diabetes. They're not prepared, right, to meet my needs. Or maybe I have patients, and I have, who have different mental illnesses and might need a caregiver, or have different genetic diseases and cannot function independently. Well, how do I still make them feel included in the education and the conversation, while also making sure that I'm keeping their caregiver involved in the conversation? And so these things are important, because to me, that's what builds trust. So if I build trust with someone, it's more likely that I'm going to improve my ability to get that patient the care that they need. One thing that we also need to be aware of is the difference between being culturally competent and having humility. So you can be aware of things, right? That, people in certain religious backgrounds might not adhere to certain health, whether it's Western medicine, maybe they believe in more herbal medicine, natural methods, those types of things. But having the actual intention of honoring those beliefs is what humility is. And that's kind of where we need to get to, where it's, again, I don't necessarily agree with every decision that patients make, but okay, I understand that these things are important to you. I need to get you treatment for cancer. Where can we meet in the middle so that I'm still able to provide adequate treatment for the patient while still honoring their actual beliefs? Because sometimes, patients feel like, well, when I have certain, deeply held beliefs or customs, and I come into a physician office, they're just going to try to tell me, oh no, that's not right. You know, those things are, you don't need teas and these different salves to help you. Like, my way is the best way. And while that might technically be true based on the data, right? There's something to be said for, sometimes when I say, okay, well, maybe we need to avoid these herbal things, but, these are okay. And now my patient's like, okay, well, maybe I'll take this chemo, but not that one, right? If I want my patient to trust me and compromise with me, we might have to also do the same thing with them in order to build that trust. Another important thing is the importance of language. Again, being able to address all people respectfully. Using person first language is the number one thing, right? That we've been trying to emphasize with students, that patients are not disease states. They are people who happen to have disease states. And it's such a subtle thing, but it does make a huge difference. I had not heard this, but I actually read this, great thing from the CDC about words like calling people vulnerable or high risk, using the words like we're going to combat diabetes or target. Like, it makes it feel like there's something wrong with people. It makes them feel like, oh, that I've done something bad, or I'm a high risk bad person, where it's just like, no, what I'm trying to actually say is, you know, treating diabetes is really complicated and it involves a huge team of people who need to help you and assist you along the way, right? It has nothing to do with you as a person, but it is going to take a lot of work, right? And a lot of different people that we're going to have to work with. We also want to remember there are different subpopulations, and I highlight this with students because, yes, we do educate them, and the hospital does that. Certain people in certain religious groups might have certain beliefs, but the way in which they feel strongly about those might vary among that population. There might be people who, in their culture, typically do not accept certain treatments, but there might be people who have that same religious belief who will. And so we try not to assume, we try to be aware that, this might happen, but we don't want to assume that they don't want a treatment without having a conversation with them first. So I included some examples of these things that and where you might see them in different pharmacy settings. So thinking about a community setting, one thing we have a specialty pharmacy in our building that we work very closely with, and one thing that we've talked to them about is in the clinic, we will print out materials and send materials through my chart in the language of the patient's preference, because although patients might speak English, if they feel more comfortable hearing complex information about cancer and chemotherapy in a different language, we want to use the language they feel the most comfortable in so that they really understand, right? But something that sometimes gets missed is we do all of that, and then downstairs the pharmacist prints the labels out in English. And so now the patient can't read the prescription labels and they don't match the education that's been customized for the patient in the language that they're comfortable in. And so I've had cases where patients have had to take 4 different medications at home that are oral with 4 different instructions for their cancer. And, the physician was having a hard time with them. And when I met with them, it was, well, all these labels are in a language they don't understand. And so they didn't even know which bottle was which medication. And so something as simple as having the labels translated, which we do have at UMass a translation service who will translate labels for us, and send us the translation comparison in English and in that language so that the patient can understand what's written on the bottles and which bottle is which. Other things can be just thinking about medication assistance programs, right? I know people don't have as much time in the community pharmacy setting, but at least letting patients know, hey, here's these copay assistance things that are here. You can read through these, having these available and highlighting them, not just having them sitting on the counter, but actually making people aware that there are these resources that are here and where they can get those. In the AM care setting, things that I think about, dietary advice is one that I've been trying to make myself more aware of. There are sometimes drugs that I use that require a specific diet around the time. And they used to give examples like, oh, you should have like tea and toast and these different things. And I remember when I had a patient, it was like, I don't eat that. Like, what should I eat? And I realized upon further reading that was actually about the fat percentage, like that they wanted a specific number of calories and a percentage of fat. And so I'm like, okay, well, what do you eat? And how can we make that fit into this number of calories, this percentage of fat, right? So it doesn't mean that you can't take the medication if you don't eat these things, but why is this recommendation like this? Other things, implementing reminders for things that consider a patient's work and family schedule. So I had a patient yesterday, who works in a factory setting, and it's like, well, maybe you need to put some of these as needed medications in a travel container and keep them in your pocket, right? If you're going to continue to do that, if you're going to be traveling, what is a safe way to travel with chemo so that, I can still go places that I want to go, and be able to work through that. And so we've worked with patients on that. I'm going to be on a cruise. I have a medication that needs to be refrigerated. I've made phone calls to companies like, well, what's available? What can the patient do? Right? Thinking about these things in advance. In the hospital setting, things such as looking at hospital formularies, One thing that, I hadn't thought about before, I've been thinking about more is pain medications that contain gelatin, which might conflict with halal or kosher dietary laws, is something that might come up in the inpatient setting. So being aware of those things, and being able to adjust pain medication protocols based on cultural views. And so I've had patients where, they keep saying that their pain is controlled, but it's obvious that it's not, right? And it's more of that, well, I was raised in a generation where men aren't supposed to complain about pain. And so we're using a PCA, but the patient's not going to use it. So maybe I need to schedule it. Maybe I need to just say, okay, well, we're going to give this pain medication at these particular times because the patient might not be likely to ask for as needed pain medication, right? And so those are some things that I can do to kind of take that onus off of the patient and get them, the medication that they need. Additional considerations we need to look for. One thing I look for in clinical trial data when I'm reviewing, is this treatment appropriate for my patient? Especially looking at things like pharmacogenomics, we have to remember that some of the recommendations that are there might be skewed because we still have an issue with getting different populations into clinical trials. And so if I'm not represented in something that's actually personalized medicine or pharmacogenomics, where I'm actually pulling samples from patients to determine which particular mutations are important, which mutations have things that are clinically that I can actually do, right? If all of my patients are of European descent and I don't have any patients that represent any other populations, it might not work the same in them. And I'm not going to know that because they're not represented in that data. And it's something that's very difficult that I know a lot of pharmaceutical companies have been working on because as the population in the world starts to shift and it becomes more intermixed, it's like you might get a trial that's from China that has majority people who are from China, but I want to use that drug in the United States. And my population does not look the same as that. How do I sort of navigate that, right? It doesn't mean I can't use that drug. We use drugs in oncology all the time that were invented overseas and tested in Asian only populations. But I just might need to be aware that the side effects might be different. The way they metabolize it might be different. The way they clear it might be different. And I need to be ready to kind of have enhanced monitoring potentially, or realize that they might not have the same outcomes as other patients might have. So it's not that, we're not going to use evidence-based medicine because of low representation, but it's that I might just have to kind of think they might not exactly follow the outcomes that patients had in that trial because they are different and it might affect things differently. And we've seen things like that with hypertension management and with other disease states that have come up, and we just need to be aware of that. The other thing is workplace culture, right? Pharmacies and the people who work in pharmacies themselves, right, are becoming more diverse. And so understanding things like everyone doesn't want Christmas off. There are other holidays and other religions and other cultures that they might want off. So I, as a supervisor, need to be aware that, you know, maybe this person doesn't mind working the Christmas holiday, but they might want a different holiday off that's not on my calendar. And can I be accommodating with them to understand that, or at least have a conversation with my employees to understand, okay, are there certain days of the year, weeks, months of the year that are important to you? And how can I work with you to ensure that, you have the opportunity to have those off too? Not just thinking about popular US holidays, but, what are other times of years? We think about things like Ramadan. I might have someone who maybe they can't work a 12-hour shift during that time period, right? Where I need to be aware of these differences and how it might affect their job performance and satisfaction. So when we think about considerations for pharmacy operations, these are some things that, I know that they have here at UMass. We talk about learning about cultural competence and inclusive policies and having mechanisms for patients and for other workers to give feedback. These can be difficult, I think, in a community pharmacy. But there are some things that we can kind of think about, like accessible spaces. So if I have a space where I'm going to be doing vaccinations, can I get in that space in a wheelchair? Can I get into that space if I'm using a walker? Is there a fall risk? Maybe I need to move it, right, to a different location. What's the visibility like? Sometimes we're asking people to sign off on things, but the lighting isn't good. And so the patient can't see it. Maybe I need to print out some vaccination forms that are in larger print so that the patient can actually read the materials that I'm handing to them. And so those are some things that I can think about. If there's a language that's commonly used here, it's Spanish and Portuguese. Maybe I have those printed out ahead of time so that if I have a patient who needs that, I'm prepared. So those are some of the things that, I try to talk to pharmacy students about in relation to what does DEI mean in pharmacy practice specific to us. Um, and that's all I have for today. Any questions, comments for me?
I think we'll just say thank you so much, Arin. It was a wonderful presentation, super informative, and thank you as well to all those who were able to make it today.
All right, thank you all. Have a good day.
Take care.